peritomy, which is a phonics-based peritomy, and you have to make sure that the exposure is good enough, because as you can see, the company recommended us to make a 5x5 millimeters scleral flap, which is quite large as compared to our traditional trabeculectomy. And we did the surgery under local anesthetic, and unlike traditional trabeculectomy, you have to advance the scleral flap to a more anterior approach into the anterior cornea, so that we can see the gray zone clearly. And similar to trabeculectomy, we have to apply anti-fibrotic agents, usually mitomycin C 0.04% in our locality, for about a few minutes. And afterwards, you can start applying the laser onto the scleral bed, which is the white zone. This is supposed to be a scleral lake to accumulate the aqueous after the aqueous percolation from the gray zone. And so the depth of the first ablation can be titrated, and so you can apply just a layer so as to accumulate the fluid. And afterwards, you can start applying the laser energy to the gray zone, where you will expect to see percolation. And so while doing this, beware of the limbus line, not to go across it, otherwise you might result in some macroperforation. As you can see, we try to look at any fluid percolation and try to gauge how much laser to go forward. And in fact, theoretically, even if you continue to apply laser in this area, the fluid will avoid further laser absorption in the surrounding tissue. Okay, so after that, as you can see, we have found adequate percolation. We will continue our surgery as usual. We will close the